So good morning, and unfortunately, as Rob said, it is a kind of a presentation, but hopefully feel free to jump in with questions that you may or may not have as I go along. So these are really important topics, these social service things that sometimes get overlooked in our communities, and I listened a little bit to the previous presentation, and I might overlap a little bit when we talk about social determinants of health, because health care overlaps. And one of the things that we're trying to create is that invisible line between regular medical care and mental health and substance use care. So the issues are all together. And so it's not as if Sally could make a presentation separately and then I come and I make a presentation separately and that the issues don't cross over, because they do. So I hope I don't repeat too much of what Sally said, but the reality is this is a significant issue in the country, as Rob said, and a significant issue in our two states, Vermont and New Hampshire. As well. So as Barbara said, I've been the CEO for 11 years. I'm actually a psychiatric nurse practitioner by background. I worked in New York City area for about 31 years before I moved up here. But I'm not a New York City person. I grew up in Whitehall, New York, if anybody knows Whitehall, New York, just on the other side of Vermont. My whole family's still there. I was happy to come back, but I spent 31 years in behavioral health in New York City area. We were the 9/11 responders. As most people remember, there was very little medical care. It was all behavioral health for the families, the companies, the firemen, the policemen. And so we stood up services for a couple, 2-3 years following 9/11. And so that was one of the big undertakings that our agency did. It was St. Vincent's Catholic Medical Centers, for people that know that area or know that hospital. I moved up here, as I said, about 10 or 11 years ago, and unfortunately the issues came with me. It's not like I came to, there's no geographic fix. Unfortunately, this stuff, mental health and substance use, is a national, and it's actually a world issue. So, behavioral health issues. To start with, the prevalence of mental health is on the rise, mental health illness. Suicide rate is increasing, and I'll talk more about that as we go. Mass shootings that we hear about all the time. I mean, Paris just had one yesterday. Doesn't matter when you turn on the news, somebody's shooting somebody. And our opioid crisis, in particular for the state of New Hampshire. Why mental health treatment is important. 1 in 5 American adults experience a mental health issue. That's a lot. Right? That's a lot. That's 20% of our population. 1 in 25 Americans live with a serious mental illness, because there's different kinds of mental illness and substance use treatment. Schizophrenia, bipolar, major depression, these are issues that can be treated, not cured for the most part. So these are chronic illnesses. And suicide is the 10th leading cause of death in the United States. It accounts for more than 41,000 American lives each year, more than double the number of lives lost to homicide, and more than the number of people that are killed in car accidents. Believe it or not. It's about 38,000 people that are killed in car accidents. And so I don't know about you all. I know it's my domain. I hear about a suicide literally almost every other week. It's gotten crazy how prevalent suicide is. And we stop reacting to it. People don't think it's a big surprise anymore, unless it happens to you. It's a big surprise. So here's New Hampshire as it compares to the United States. So in the U.S., it's about 7.6 per 100,000 people of suicide deaths. New Hampshire, 7.8 total. Grafton County, 7.5. Look at Sullivan County. Right? And that's ages 10 to 24. These are kids. And then we have our adult population, all ages. And still look at Sullivan County. But you know, Grafton's not that far behind. That's like one person. We're not talking about a lot. It's still higher than the national average. And it's something that we need to be very aware of and train ourselves to do something about it, which I'll talk more about. In New Hampshire, 21.67% of the population, or 227,000 people, are dealing with mental illness. That's a lot of people. Almost everybody knows somebody. If you think about it, you know somebody who's dealing with a substance use issue, whether it's themselves or a family member or a next door neighbor. Mental health, same thing, mental illness. Somebody knows somebody who's dealing with these issues. And the suicide rates across the country, as I said, are at their highest level in more than 30 years. We have the second highest rate of opioid-related overdose deaths in the country. Nearly 3 times higher than the national rate. And emergency room visits for opioid use rose by 10%. And we'll talk a little bit about what else is in those emergency rooms called psychiatric patients that can't get an inpatient bed. So they're sitting in there with the opioid people, and they're sitting there for days and weeks waiting to get an inpatient bed to be treated. So those emergency rooms are really busy, and they're not treating medical problems as much as they're treating behavioral health problems. And they're not happy about it either, and nor are the patients. But let me just be clear on something too. The opioid crisis has drawn a ton of attention because people are literally dropping dead. But the reality is something that we don't deal with very much anymore is alcohol use kills more than 3 times as many people as the opioid crisis. But nobody talks about that. It's much more insidious. It's much more insidious. It's much more, you don't see it as, you don't drop dead on the streets. And so it's a long term. You have medical problems. You get care and treatment. It drags on. It drags on. In the end, it kills you. But we don't talk about alcohol because somehow that's something that we just take off the table. And a lot of people don't even consider that substance use. And we've tolerated it because it's legal. But the reality is when we talk about substance use, we need to include alcohol because it's killing our population 3 times as many as opioid. But they don't drop dead. So when we think about alcohol use, so this is our youth risk behavior surveys that we do in the school systems. And so when we talk about currently drinking any alcohol in the past 30 days, almost 30% of the kids in the schools are drinking some alcohol. And drinking 5 or more drinks of alcohol in a row, 16%. That's a lot of drinking. But again, you talk to some people say it's part of growing up. So let's talk about the impact of mental health and substance use on employers. Because this is a big issue, because people say, well, you know, I don't see it every day. There's not really any big impact to my work. So, and again, these are rough estimates. You know, people can't actually do this scientifically as well as you'd like them to. So these are rough estimates. But the national, the survey that they did, they estimated that $225.8 billion each year is lost on people that have an untreated mental health or substance use issue. So the one thing they can measure pretty clearly is that 20% of lost productivity are due to absenteeism. That's pretty easy to measure. They're not there. They don't show up. What they're not measuring is that 80% of it, presenteeism is an interesting word. I think they made that up, but it is a word. And it means that people show up at work, but they don't function at the highest capacity that they can function. That's hard to measure. We all know those people. We all know those people. But 80% of it is because people come to work with a untreated mental illness or untreated substance use disorder, and you're not getting their best performance. And so the combination is billions of dollars to our employers. Estimated individuals working with untreated illness, $1,601 per person per year is what it costs to have an employee that's not treated. So let me talk a little bit about the work that we do. Because of all of that, most of the states across the country stand up what's called community mental health systems, or community mental health centers, but systems. I'm only talking about New Hampshire right now. Vermont has HCRS, Clara Martin, very similar to what we have on the New Hampshire side. The only real line between the two states is Medicaid. The states do not want us to share Medicaid clients because, and understandably, the states need to control their Medicaid spend. The states right now match about 50% of the spend, and the federal government matches the other 50% of the Medicaid spend. And so the states really want to control how much that is. So very rarely do Medicaid patients without special deals go across state lines. Medicare is a federal insurance. We can take that as well as Vermont. Any private insurances, Blue Cross Blue Shield, Cigna, those kinds of things, we can share those across the state lines. It's really just the Medicaid clients that have to be in their own state for the most part. So our community mental health centers, there are 10 of us in the state of New Hampshire. Our mission, and we just changed this mission, which is it's a really important mission, and we just changed it because we wanted to make it a little bit more positive. Our mission last year, before we did our new strategic plan and our board vetted this, was to reduce the burden of mental illness, and people thought that was too negative. Now, if anybody knows anybody that's dealt with a mental illness or a substance use disorder, it is a tremendous burden. People often think that these folks just want to get on the system, and even to keep their benefits is a full-time job. Even if they deserve the benefits and they need the benefits, keeping them is a full-time job. Every day they get a letter that says, oh, well, you're dropped off, or no, you didn't do this, or you didn't do, and so constantly they're in and out of whether they're covered, whether they can get care, whether their Medicaid is active, it is a full-time job. And so these people are not on the system and not needing it. They need the insurance so that they can get the care and treatment that they need. So anyway, we changed it to promote the health and quality of the life of the individuals that we serve, not to reduce the burden. And so it's a little more positive, and we wanted to have that message out there more than the fact that it's a burden, although it is a burden. And as I heard the tail end of Sally's conversation, we consider it part of our responsibility to work on reducing the stigma. Because if we don't reduce the stigma, as she said, people are not going to get treatment. People are not going to talk about it. It's particularly challenging for those of us that are in the business and we're trying to raise money. Because if you go to Dartmouth and you have open heart surgery and it was a success, or if it was bad, either way, you're going to talk about it. Right? You're going to tell your neighbors, gosh, I went up there, I got great care, everything was terrific, you know, and if you need open heart surgery, that's where you want to go. People come to us for treatment and nobody says a word. They don't tell nobody. They don't tell their neighbors, they don't tell anybody because the stigma is alive and well. And as Sally said, if she presented in a certain way and, you know, with a particular diagnosis, whether it's diabetes or whether it was a substance use disorder, I usually use the phrase that if you knew that your neighbor was getting substance use treatment, would you think differently about him? Or mental health treatment, would you think differently about him? And afterwards, some people come up and they go, you know, I never thought about it, but I think I would. If you're honest with yourself, would it matter that they're next door? Or a family member that would come to you and say, by the way, I just had this really serious depression. I went and got treatment and I'm better. And it worked. Would you think differently of them? Because we do judge it. We think that people, as we said, New Hampshire, pull up by the bootstraps, get over it. These are medical problems. They're medical conditions that need treatment. This is not willful. It's not volitional. It's a really important thing to think about when people are seeking treatment. It's not that they can just do this on their own. There's known studies out there that talk about the scientific evidence that these are medical problems. So our vision, and this is really important for us, our vision is that people will get behavioral health services when they need them. And I'm going to talk a little bit about towards the end about what we did to make that happen. We've had that as part of our vision, that will be fully available as needed for forever. We wanted it to be. We didn't make it happen, but it was our vision. So we finally, about a year and a half ago, made that happen. But it took a very long time to get there and a lot of changes. So just to see where we are, as I said before, these lines are really invisible to the patients. They're only visible to us the 10 community mental health centers. And so the patients can go anywhere they want to go, essentially. But what this means for us is that if anything happens in this area, those towns and cities, the state calls us. And just as a matter of fact, in the last month and a half, we've gotten 3 calls for suicides that were not our patients. They're untreated, not our patients. 3 calls, 6 weeks. If anybody's, you know, listening out there, you very rarely will see it in the paper still. Every now and then somebody will say died by suicide, but most of the time it's a sudden death and it's a young person. And so we've had 3 calls. So what we do is we have an emergency services team that is available in our catchment area that goes out to the people that are involved in that. And we reach out to the police that may be a first responder, reach out to family members, reach out to whoever's impacted in the community to see if we can assist. So that's what the catchment area is for. That means it's our responsibility to work with our communities, whether or not they're our patients. It doesn't matter. It matters that it's our community and that we see that all of these towns and cities, that we will respond to those kinds of things. We also do things like our emergency services team. Anybody remember the story a couple years ago where 4 kids were killed in Claremont in a car accident? And we went out and responded to the school, to the families, to the other students, to the, you know, it's just the work that the community mental health centers do. But again, the patients can go, if somebody lives down in here and they want to go over to this community mental health center, they can do that. It's not. The other important thing is that the 10 community mental health centers are not state agencies. We are not funded by the state. We are not operated by the state. We are freestanding nonprofits. We have to raise our own money. We have to make sure that our bottom line, that we have a positive bottom line at the end of the year as often as we can. It's not always positive bottom line, but it's ours. We have a board of 14 board members that are our local community and from the Newport, Claremont, and Lebanon area that works with our agency to really promote and to really lay out where the agency should be going over the years. As I said, we just finished our strategic plan for the next 3 years. And I talk about West Central because, 1, I know it best, but 2, it really is only an example of what is out in the communities. And so it's important to understand what the community mental health centers can do, not so much West Central, but understanding we pretty much all do the same thing so that you know what services are available from your community. I don't want this area. Can you imagine?
Kind of question about
Yes.
So, I don't fully understand. So, like, West Central is a nonprofit, so
Hmm?
you don't receive any funding from the state.
We receive Medicaid when we provide a service and bill.
Okay.
No funding.
But then you also are tasked with providing mental health services to the area. Okay.
That's right. To that whole area. Whether we can bill for it or not, of course, those services that I just talked about are non-billable. We're not going to bill the school or the kids or the families or, there's a lot of services that just are not billable. And that's why I say there's no direct funding from the state to work with these agencies. It's only if we do, and actually we just changed our payment model to a capitation model, which I don't want to get into too much because it'll slow down the process, but it's a little bit different than fee-for-service. It's actually better for the centers that we're on a capitation model, which means we get paid a per member per month amount versus a fee-for-service model for some of our patients, not the entirety of the organization. But it's sort of a new model that where people are trying to, when you think about new payment models that people are talking about right now, fee-for-service doesn't work. I don't know if Sally talked about it too much, but in our healthcare system, fee-for-service does not work, and it will not work for the future. And so we are the only agencies in the state of New Hampshire right now that are on this capitation model, that we're sort of out front doing this, and it's been positive, yes.
I'm just curious, when you say per person per, who's paying that? Is that the insurance company?
Medicaid. Instead of paying fee-for-service, so every time we provide a service that we bill Medicaid, we bill the state for Medicaid, we get a per member per month rate that's been negotiated based on the severity of the illness. It's kind of an interesting way to pay for people, but we put in a file on the 1st of the month, we get paid on the 20th of the month. It's almost like a prepayment. We provide whatever services that need to be provided. But again, it's only for about a half of the population that we serve. The rest of the population is all fee-for-service still. But it's a new model, and it has a bright future that other people are looking at to see whether they're going to adopt that model in other areas of the state. But it is a capitation model in all 10 community behavioral health centers in New Hampshire. So these are all the services that we provide. Essentially, we provide all medical services. Our staff is comprised of physicians, MDs, advanced nurse practitioners, social workers, vocational workers, case managers. All kinds of work is done around, because it's wraparound services for our clients. So we have a real team approach. They actually meet in team meetings to talk about these folks, because we believe that diversity and staff is really, really helpful in taking care of patients. They all bring a different viewpoint when you think about what the needs are. The social determinants of health are much more powerful than the illness that anybody may have. It impacts on their ability to either get well, get treatment. And so those are things that people didn't look at before. We often looked at people in a vacuum, meaning when people came to us for services, us meaning any behavioral health entity, we thought that, gosh, if we could make them think better and function better, that we were done, and we didn't take responsibility for the physical conditions that we may or may not have caused from the medications that we ordered. And so we were very siloed in our pieces of that person. And now you're going to hear a whole lot more. The language out there right now is integrated care. We started doing it a little while ago in a lot of places. It's not a brand new thought. I mean, people did have this thought before. How to make it happen with payment models and all other kinds of restrictions makes it sometimes real difficult to do. But the concept has been out there for years and years. People really understand that you can't treat a medical condition if somebody has an active mental illness that's going on. When we think about the cost, if somebody has a medical condition with a co-occurring mental health disorder, it often costs 3 times more to treat that person than somebody that does not have a co-occurring mental health disorder. So when you think about the cost, you wonder, why are we not looking at this in a different way? A cost to employers, cost to states, cost to the people. You know what I mean? It's a tremendous issue. But again, part of that is related to the stigma. Part of it is related to people lack of education. People don't know what to do with it. It's frightening, it's overwhelming, and people don't know what to do with it. And so since we don't know things, we often just push them aside because we don't know what else to do with it. So it's an important piece, yes.
How do your services complement or compete with hospitals?
So we work very closely with all of our hospitals. We cover the emergency rooms in a lot of these hospitals for all behavioral health problems, and they send people out to us for follow-up care. We're the ambulatory arm of the hospitals. And so what happens is people go, you might have an inpatient hospitalization at Dartmouth-Hitchcock. There's a couple of inpatient units up there that we work with. If patients are voluntary, they can go into that hospital. And then when they're released, we go back and forth. When we manage them when they're out in the community, and if people get more ill, then they go back in a hospital, and we work together to manage the whole. And similarly, if they go on inpatient for a medical condition, we follow up with those with the primary care as well, so that we try to look at the whole picture and work together, and again, not in silos as much as we can. One of the issues that you may or may not be aware of, or often is a barrier, because of the stigma. In order to share information with primary care, we have to all but get a lawyer to come let us release information to anybody. When you're talking about good care, you need to share information. But the stigma has really made it that the federal government protects people because they have to protect them. But with substance use and mental health disorders, I mean, we want to share information. We are constantly telling people we can't talk about it. We get releases signed. We do everything we can do to share information. But it's unfortunate, and that's related to the stigma, that people don't want people to know that they have mental health treatment or substance use treatment. We have people come to us and say, I don't want you to use my insurance. I'll pay out of pocket. I don't want to use my insurance. Because that stigma is out there. And so what happens is it's a real barrier, that sharing of information. But we do everything we can do to do it reasonably and rationally so that people that need to have information about what we do and what we prescribe get it appropriately. But it is we talk about shared decision making and shared treatment plans and it's really hard to do in the field of behavioral health because of those barriers. So anyway, we do medication management. We treat anybody, the youngest person I think that we've treated is 3. And there's no limit on the other end. We do a lot more services are provided in the community than they are in our offices. We are a community-based agency, and so we do team meetings and we set up treatment plans, and then we have case managers that go out in the community and work with people, children, adults in their homes. And then we have an ACT team for people that's called assertive community treatment, people that can't come into routine treatment into the building. We have a group that goes out to the homes and works with the families and works with the children, because you can't work with children in an office with no family and no environment to deal with. So we do all of that treatment. We also do work-related, as do all the other community mental health agencies. We have a vocational program, because our folks that might be mentally ill and dealing with chronic issues, they want the same life that we all have, that you all have. They want work, they want families, they want relationships, they want the same things. And so we help them to manage their illness so that they can go to work. And we do have a lot of people that are working in the Upper Valley. And it really makes a big difference of people's level of functioning and their sense of well-being if they can work. They're not trying to get out of work. Most times their illness impacts their ability to be able to work. So this is what we do. We are in the communities, as I said before. We are in the jails. Law enforcement, we are in both the jails. Sullivan County and Grafton County. When I say we are in the jails, we have staff that are in the actual jail system that provide treatment services and medication management for people that might be in there. Unfortunately, our jails have become our state hospitals. Back in the 60s, for people that may or may not remember the Kennedy era, when people turned people out of the state hospitals, and it was a really good idea because people did not need to be in those state hospitals for their whole lives. That was a good idea. Not funding the communities to take care of those people when they turned them out is not such a good idea. And that's what happened. When Kennedy did that, I mean, we had thousands and thousands and thousands of people in state hospitals for their whole life. And if you ever know a state hospital in your area and you look around, there's probably a cemetery very close to that state hospital. People lived their lives, died, and were buried on the state hospital properties because people didn't know how to, and there was not good treatment back then. It was terrifying. There was not good treatment. People stayed their whole lives. By the time we got to the 60s and 70s, we had better medications, better treatment, and these people did not need to be in these hospitals. And so literally thousands of people were turned out of these state hospitals to community mental health centers. That's where the community mental health center started. And you can manage people in the community for the most part. Only severely ill people need to be in the hospital and for short periods of time. But they stayed for years and years. And so now, unfortunately, when you can't find beds and you can't, our people, sometimes the symptoms of our folks will get them in crosshairs with the law, but it's because of their illness often. And there is a mental health court here in Leb, which is really terrific. We work with them, and if people are arrested because of symptoms of their mental illness, they can go into this drug court. We work with them. They have to present before the judge. They have to agree to treatment, and they don't have to serve jail time. But it has to be related to their mental illness. And so it's a really, really good, it's over 10 years now that the mental health court in Lebanon. They're all across the state. They're not in every county, but they're all across the state. But anyway, so we're in the jails, again, because people get in there because of their illness. We work with the hospital emergency rooms and in the hospital to do assessments. We work with the schools. We are in most of the schools in our area, Claremont, Newport, and Lebanon. That's where our offices are and our services. And we are in most of those schools. And we do a program called Mental Health First Aid, if people haven't heard about it. It's an 8-hour course that we started a number of years ago now, about 5-6 years ago. If you have the opportunity to ever take that course, anybody that's taken that course that I'm aware of has thought that it was extremely beneficial. Anybody taken that course? Wow. Did you think it was beneficial?
Yes.
People walked away, the two things when they do the surveys, the two things that people walked away with was a better understanding of mental illness and substance use and an empathy for the people that have it. Those were two, not only the signs and symptoms and what to look for, but the understanding that these people, you know, if they could not be mentally ill, they would choose not to be, or a substance using person. So if you have an opportunity to do that, we offer 6 a year. They're free, open to the public. So they're usually in the newspaper that we run an ad or something, or go to our website, wcbh.org, and they'll be posted on there for the next year. If they're not there yet, they're actually figuring out the next 6 over next year. But stay tuned, and the 6 of them will be posted about when you can take the mental health first aid course. These are our offices. As I said before, we have adult and child in the Rivermill complex down here. We have adult and child services in Lebanon. And in Claremont, we have adult and child services on Pleasant Street, not in the same building, down the block. We keep child services so that the high school can walk. Families don't get out of work to come take their kids to treatment. So we try to put the treatment where the schools are so the kids can get there on their own. And then we have a couple of apartments, and we have a residential facility. We have an apartment building in Claremont, 5 apartments for people who are independent living. We work with them, but they live on their own. And we have a 16-bed residential facility. And again, all of these services that we provide, they're not identical, but most of the community mental health centers do something in that arena. Housing is a big issue for us. We do work well with Twin Pines. We all work well together. Headrest, we have substance use services in Claremont. We do not have substance use services up in this area, West Central, because we have Headrest, who you're going to talk to coming up. Or Cameron didn't come yet, right? Cameron Ford, is he coming?
He'll be here this afternoon.
He'll be here this afternoon. Cameron is the executive director of Headrest. So they have services here in Lebanon, so we don't trip over each other. We have limited resources, so we try not to duplicate services. And so he does it up here. Dartmouth-Hitchcock has a great intensive outpatient program at Rivermill, so we work with them, and we refer our local people here to there. Claremont had no services, believe it or not. A few private practitioners, no substance use services in Claremont. So this past few months back in April, we opened up an outpatient substance use program right across from Valley Regional on Elm Street down there to provide substance use services down there. So we're very conscious of what we're all doing so that we don't trip over each other and end up doing the same things. Current issues, there are, as you heard me say before, there's a critical shortage of inpatient beds, and that's across the country, by the way. New Hampshire has their own issues of how we got here, but everybody got there. You know, our issues were because every budget year, they closed an inpatient bed to save money, inpatient unit down at the state hospital down in Concord. They would close a unit and save money. And then the next year, they'd close a unit and save money. And we all said, you know, you're going to hit the wall. You can't keep closing these units. Well, we've hit the wall. So for the past 2 or 3 years, our folks are sitting in emergency rooms days, weeks, months. You may or may not have seen the current lawsuit that the ACLU filed against the state of New Hampshire, because technically by law, these folks that go to these emergency rooms and are held against their will, involuntarily held against their will, are entitled to a hearing in 3 days. That's the law in New Hampshire. Within 3 days, we either keep you or you're released. But you're entitled to a hearing within 3 days. Well, guess what's not happening in the emergency rooms? There are no hearings. People are being kept for weeks and sometimes months in those emergency rooms, against their will, with no hearings. So the ACLU filed a lawsuit against the state of New Hampshire, which is all good and, you know, fine, file a lawsuit. Getting them a hearing is not the problem. Getting them a bed is the problem. So it's a little bit of noise out there, but it's not the solution. The solution is finding these people appropriate treatment at the time they need it. It's not just getting them a hearing for 3 days that we get to keep you then. Significant, nobody's going into the field anymore. When I was young, and you heard us say I've been in the field for way too long, but when I was young, there were not a lot of choices for women in the workplace. And people had families, and they wanted to have jobs and careers where they could be home with kids. And so they were nurses, they were secretaries, they were social workers, they were teachers. They were home for the summer with the kids. Now, people can be astronauts, women. Nobody's going into the field. The whole social work field is primarily women. Has been forever. So is nursing, even though there's a few more men coming in, but so is nursing. And with women having all the choices they have in this world, they're not choosing these social service jobs that pay them nothing, and it's really, really hard work. Why would anybody choose that? I don't know. I don't know that I'd do it again. It doesn't make any logical sense, so therefore nobody's going into these fields when you have so many other choices and you're going to make a boatload of money different than what you're going to make in these community mental health centers. So we've got to do something about that workforce shortage. So part of the solution is tuition forgiveness. We're doing all kinds of things like that to try to, if you work for our agency, you can be part of what they call the SLRP, State Loan Repayment Program, and you can get up to like $50,000, $60,000 of your loans forgiven. But there are only certain agencies, if you work there, that you can apply for those state loan forgiveness programs. So we're trying to do everything that we can do to draw people into the field, but boy, it's a hard one. Nobody's going into it. And again, justifiably so. Reductions in the state and federal supports, stagnant Medicaid reimbursement. This year, 2018, we finally had a tiny, tiny move on Medicaid rates. No move on Medicaid rates in the state of New Hampshire since 2006. 2006. Can you imagine running a business with rates not changing? They wonder why our people don't get raises, why they don't join the field. 2006, the state of New Hampshire has not increased them. So right now they did a minor little adjustment for 18, but only for some services, not across the board. So we do a lot of advocacy with the legislature. I do a lot of testifying before the state legislature on unique issues and also on funding. And again, the current issues, this opioid crisis, we haven't begun to, yes?
I want to touch a little bit on people not going into the field.
Yep.
My daughter just graduated with her MSW from Washington University in May. And unfortunately, she's not coming back here. She wants to stay in St. Louis, but it's a licensing issue as well.
Yes, it is.
It's not just going for the education, which she paid $46,000 a year to get.
Yep.
For 2 years. Now she has to pay to get licensed.
Yep.
As well. And one of the reasons she doesn't want to come back to New Hampshire is because it's so difficult to get licensed in this state.
Mm-hmm.
Can you comment?
I can comment on that. It's a real issue for us, and there's no reciprocity. And so people have to come back and fight to be licensed. But what we do in the community mental health system is we have a lot of young people, and unfortunately we end up like Vermont. I've heard Vermont talk about the same thing in the community mental health centers. They need 3 years of supervision in order to get licensed. And what happens is we provide that 3 years of supervision, they get licensed and they leave. Because then they can make more money doing private practice. And that's the vicious cycle that we're all on. Is that but we provide the 3 years of supervision for free. It's a draw to try to get people at least into the community mental health centers for at least 3 years, and then we ask for a 2-year commitment beyond that. If we're going to give you 3 years of supervision for free, then we ask for at least 2 years as a licensed professional after that, and then go where you need to go. But it is a big issue. People come into the state, they can't get licensed in New Hampshire because of our boards, and we've addressed that at different times with our legislature. They actually did pass a law here that says if you're not licensed within 10 days of coming into the state as a licensed social worker, that you will automatically be licensed unless there's an issue. Well, that unless there's an issue is the issue. Right? Because they're going to find some piece of paper you didn't sign or something. Once they find that, well, that 10-day thing goes out the window, so it doesn't really help us at all. But licensing is a very big issue. People don't come back here, but we do provide that licensing for free, yes.
You're talking about community mental health centers, but it seems like there's a shortage of private practitioners in the area.
There is. There is. Because people aren't going into the field. Right? Whether they're private practitioners or not, because we're not seeing as many people come in that we're supervising, and therefore we're not turning on as many licensed people in the private arena either. But yes, almost everybody up here that's a private practitioner has worked at West Central Behavioral Health. Every time I meet somebody in the community, like, oh yeah, I worked there in the 90s, or yeah, I worked there in the early 2000s, or there's only one entrance. And almost everybody spent some time with us at one point or another if you're in the field of behavioral health. It's a great agency. Let me move on here. This is the last thing I'm going to talk about. So, when I talked about accessing services when people need them, 2 years ago we had a waiting list of 223 people. So how good is that when you call up any of our community mental health agencies asking for services, and we say, yep, let me get your name, talk to me about what's going on. If it was an emergency, we dealt with it. If it was just a call that you wanted services, we put you on a line someplace and said, yeah, we'll get back to you. But if anything happens, you can call our emergency services. So we didn't leave them out there without a string at least attached to them, but they didn't get any ongoing services until we had discharges or people that, you know, went out of the system. If you could get into West Central Behavioral Health, people had very good things to say about the agency. Just because we see a lot of Medicaid people doesn't mean we don't provide really good care. There's no correlation between the insurance that you have for coverage and the quality of care that you're getting. There's no correlation between that. So we provide really, really good care, but you couldn't get in. And so we embarked on this thing called Access Redesign. And we did this a year and a half ago. And a year before that is when we started. So 2.5 years ago, we decided we needed to do something different than have a waiting list of 223 people. It was not acceptable. Our staff was stressed by it. The community was stressed by it. Every time our staff went out in the community, somebody said, can you get me in there? I have a couple of kids that I want to be seen. Nobody could get in. So we embarked on this. We raised money, because of course we don't have any money to do this. And so we hired a consultant that's done this in over 900 different behavioral health organizations. So we raised money, we got a grant, and we embarked on this. And it took us a year to put together the infrastructure that had to be in place to be able to do this. And so you can imagine our staff with a waiting list of 223 people on it. When we said we're going to do Access Redesign, now people are going to be seen within the week that they call us. They thought that was going to happen. And you can't blame them. You got a waiting list of 223 people. The reality is this. Only about 2/3 of the people, sometimes less, 1/2 to 2/3 of the people that call us ever actually come in for treatment. So we had a big, long list before. So about 3 weeks before we went live with this act, meaning we're going to tell you to come in. We don't do appointments anymore. We tell you to come in between different hours and different when you call our intake person. It's one intake number for the whole agency. Depending on what your needs are, she's going to say, come in this week, Monday, Tuesday, Thursday, between 8 and 11:30. Because the biggest no-show rate is the first visit. And we had all these people sitting out and all these therapy slots out there that never showed up. And so we looked for efficiencies of how to manage our staff with a little bit that we had. And so if people don't show up, it's on that front end. And it's not throughout everybody's schedules all the time. We now have an 11% no-show rate, which is very low for a community mental health agency. Because we make sure that people that are motivated for treatment can get here and can, you know, a lot of people call in the middle of a crisis. The crisis resolves, we never see them. Some people call, they come in for 1 or 2 visits, and they don't come back. So we don't have all long-term people in our system. But what we had to do was we had to move people through the system that were stable and were able to be seen in a much lower level of care. So we had to create different levels of care to move people through, to open up the front door, to get new people in. And so now when you call, you'll be told to come in during a particular time. If for some reason we have a big influx, 3 or 4 people at a time, we have backup clinicians that'll be seen that can see people. So we try not to have more than a 30-minute wait. And that's how we've managed our Access Redesign. And so for the most part, I'm not going to say 100% of the time, depends on the specialty that you might need. For the most part, you can get into the program within a week. And that's across the system. And so that was a tremendous challenge to do the Access Redesign, but we as an agency thought that it was important and part of our community effort to be available to people when they needed us. But it was a big undertaking. These are 2 numbers you may want to write down if you live in the New Hampshire side. People, who doesn't know somebody that may need services at any given time? Our intake number, as I said, is a centralized number, and it will get you to any services that we provide in our area. Our emergency services covers that catchment area, and you don't have to be a patient. This is anybody that's in a mental health crisis. I'm done.